my topic. But again, I'm Heather Young. I'm one of the pediatric ID docs here at Children's, and let's get started. I have no disclosures, and our learning objectives would be that hopefully after this, you will be better able to interpret the various syphilis testing results in an infant and the infant's mother, to differentiate between the AAP categories of congenital syphilis, and to plan the evaluation and treatment of a child exposed to congenital syphilis. So syphilis, as you guys might remember from medical school, is caused by the organism Treponema pallidum. It's a spirochete. It cannot be grown in culture. Therefore, you can't really test for it very well. You either have to get dark field microscopy from an active lesion or do indirect testing, such as basically serology. And so it's kind of a pain from that standpoint. It is spread through direct and sexual contact. So there are different stages of syphilis in adults. So you start with the primary syphilis with the painless chancre at the site of inoculation. If untreated, goes on to secondary syphilis, where you have the rash that's on the palms and soles, as well as fever, lymphadenopathy. That will go away if untreated and remit. And then later on in life, you can have tertiary syphilis, where you have these gummatous lesions in the viscera and also in the cardiovascular system. In between those times, you have latent syphilis, where you have absolutely no clinical manifestations whatsoever, but you have a positive serologic test. So it's such a sneaky little organism like that. And then neurosyphilis can occur at any point in time along the spectrum. So somebody can come in with a chancre and actually have neurosyphilis at the same time. So it's a very interesting organism from that standpoint. Now, when we talk about latent syphilis, there's definitions of latent syphilis, and it becomes important later when we talk about treatment. So basically, again, latent syphilis is no clinical manifestations, but positive serology. If you have somebody who is serially tested, like somebody who's been incarcerated several times, or pregnant, a mother who's been pregnant several times and therefore has gotten lots of different screens, you can sometimes tell when somebody's had a negative RPR in year 2019, and then in 2020, all of a sudden their RPR is positive, but they don't have any clinical manifestations. That is called early latent syphilis because it had to have been acquired during the past year. So late latent syphilis is also known as latent syphilis of unknown duration. And if you don't have those serial serologic tests, then and you just have somebody comes in randomly and they have a positive test, then you put them in that late latent syphilis or latent syphilis of unknown duration bracket. And that comes into more importance later when we talk about treatment. All right, syphilis in pregnancy. So there are higher rates of miscarriage, there are higher rates of stillbirth. Babies can develop non-immune hydrops, and then they can be born with congenital syphilis. So it is a significant problem during pregnancy. Maternal risk factors have been identified as having sex with multiple partners, transactional sex, or sex in conjunction with drug use, having late. Sorry, was that a question out there? No. Okay. Late or no prenatal care, methamphetamine or heroin use, incarceration in the family, either in the mother or her partner, or being in unstable housing or homelessness. So the CDC guidelines for maternal screening in high-risk populations, which honestly includes the entire population of Arkansas, is that you are screened for syphilis at the first prenatal visit, again at 28 weeks gestation, and at delivery. And then all of those risk factors that I talked about before, they're very specific in saying that if you're at delivery and you have a woman who has any of those risk factors whatsoever, those are the women you definitely by all means need to be checking to make sure that you have syphilis testing done and documented before discharge. So syphilis through the years, so if you look at it, this data is from 2018. So back in the 1940s, before penicillin came around, we had very high rates in the United States penicillin comes into play, we realized that it works against syphilis, and then the rates skyrocketed down. See it falling here. You have this little blip here in the late 80s, early 90s with the HIV crisis. Then we seemed to get that under control. And we actually had in the year 2000, that was our lowest rates ever at that point in time. But then since that time, you have this little uptick, and this little uptick may not look that big right now. But if you look at it this way, you'll see that this rate is actually rising astronomically in the past 10 years. So, and this is just total, this is syphilis in adults here. So congenital syphilis, there is hematogenous infection from mother to the infant. It crosses the placenta, and sometimes you can see characteristic pathologic findings on the placenta. So I know not every hospital will do placental examinations. UAMS certainly does, or you can at least request it. But I've had plenty of babies born at other hospitals where you're like, oh man, it'd be really nice if you guys had that placenta. And they're like, no, we don't have that placenta anymore. But you that could potentially be helpful for you. But once you crosses the placenta, it can cause disseminated disease in the fetus and the neonate. And that disease is a spectrum. A lot of these neonates will be asymptomatic and won't develop disease until later. Early congenital syphilis, which is defined as congenital syphilis identified at under 2 years of age. So that can present with jaundice, severe anemia with high drops, CSF abnormalities, nephritis, retinitis, or having intrauterine growth restriction, or they may not have any symptoms at all initially at birth. But there's some images here. This is an infant with hepatosplenomegaly from congenital syphilis. This is a child with snuffles from syphilis. That's these thick white secretions from the nares that it looks like thick, pure white snot, and it's actually teeming with spirochetes and very contagious. Then these are called regades, are these little linear fissures that are around the oropharynx, and that can actually cause some permanent scarring. And then this is the characteristic rash that you see with infants sometimes born with congenital syphilis with all of the peeling. And then here on x-rays, you can see the periostitis here, and you can see it looks like almost like the metaphyses are almost just completely eaten up here on this x-ray. So that is what classic early congenital syphilis can look like. But again, a lot of these children will initially at birth be completely asymptomatic, and you won't see this until closer to 6 weeks of life. So late congenital syphilis, that can occur if you miss those infants who don't have symptoms, and up to 40% of those children can develop these findings. So that includes mulberry moon molars. They can have bone and joint changes, which includes a saddle nose or saber shins, some frontal bossing, something called Clutton's joints. And especially around the time of puberty, the Hutchinson's triad tends to become apparent, where kids have Hutchinson's teeth and interstitial keratitis and eighth cranial nerve deafness. So this is Hutchinson teeth right here, these kind of notched incisors. And then over here, you have the mulberry kind of moon molars. So anyway, that is, again, syphilis after 2 years, congenital syphilis manifesting after 2 years of life. So for my first case, I've got a 23-year-old mother who presents to labor and delivery at 34 weeks with acutely decreased fetal movement, non-reassuring fetal heart tones. And she comes in for an emergency C-section. And the baby immediately at delivery is jaundice, blueberry muffin appearance, grossly anosarchic, sick with respiratory distress requiring the oscillator. And they start the baby initially empirically on Amgen and ganciclovir because they were worried with this blueberry muffin appearance about CMV. On her initial labs, white count was a little elevated at 19, but her hemoglobin was only 4.9. And her platelets were low at 47, some transaminitis with hyperbilirubinemia, and this child was acidotic. So they do a workup and they checked for HSV, they checked for CMV twice actually, hoping that there was a false negative. Toxoplasmosis rubella, all of those were negative and the blood culture was no growth. And without any answers, they sent them over to Children's. When the child arrived here, I talked with the mom and she tells me that the father of the child's being checked for abnormal lymph nodes. And she says that she herself has had a rash for the past 2 months and it involves her palms and soles. And so then we look at her first prenatal lab visits, and there, what was noticeable was that she had trichomonas. So she has an STI at her first prenatal visit, which should set off some alarm bells. So that happened in the first prenatal visit. There was no testing done at 28 weeks. Hold on. But at delivery, mom had an RPR of 1 to 32, but nobody had followed up on it. And so we check an RPR at our hospital, and our baby's RPR was 1 to 256. So, and then we look at a skeletal survey, and you can see kind of the metaphysis of these long bones here in the radius and the ulnar and the tibia and the fibula that are just kind of thinning out. On CNS evaluation, the baby was so anasarchic, nobody was able to obtain a lumbar puncture, but at the time we did an MRI and it showed a subacute infarct in the left temporal lobe and left-sided labyrinthitis, which it can be seen in syphilis. So this child had neurosyphilis as well as severe disease from syphilis. So ended up being treated for 10 days with IV penicillin after we figured out what was going on. So congenital syphilis rates. So this is rates of primary and secondary syphilis in the United States. And the blue bars are the congenital syphilis rates. And just as the primary and secondary syphilis rates are going up, so are the congenital syphilis rates. And that Arkansas is in the blue. So we are like number 6 in the United States as far as rates of congenital syphilis. So not a great statistic to be. When we look at what do these children look like with congenital syphilis, a significant proportion of them are alive but have no documented signs and symptoms. So you really have to rely on maternal testing and testing of the infant to really identify these kids. But many of them do have signs and symptoms, but then there's all of these kids here who have no documented signs and symptoms. So another way to put this, in 2013, there were 362 cases of congenital syphilis nationwide, and in 2019, there were 1,870 cases. So again, just a terrible trajectory to be on. So we look at, all right, so we have all these moms. How are we failing these babies? What are our missed opportunities? So you can see that things have kind of changed over the years. So this purple group is where this group of moms were adequately diagnosed, but they did not receive treatment for whatever reason. There were barriers to their care. The hot pink group is basically these moms had no prenatal care and there was no diagnosis. And so that's where how the babies slipped through. So the orange group is this group of kids here who moms got were identified late during pregnancy. Like they must have acquired the infection late during pregnancy. And then we have this green group, which is the group that kind of hurts my heart the most. So this is moms who had regular prenatal care, but they did not have adequate testing. And so these moms were doing everything right. It was the healthcare system that failed them. And that bothers me. Then there's this darker green group where basically these are the moms were treated adequately, but there are still concerns for syphilis and in the infant despite treatment. So of the mother. All right, so what is adequate maternal treatment? So during pregnancy, the answer is penicillin. And one of the kickers is it's 2.4 million units of benzathine. And the benzathine that you get for strep throat is 1.2 million units in those those syringes. So it takes technically 2 shots. And so, but sometimes we've had it where a mom only got one shot instead of the two. So really have to make sure and verify that it was actually that 2.4 million units. If the mom is allergic, they have to be desensitized. There is no alternative option during pregnancy. And for whatever regimen, that last dose of penicillin has to be in the mom over 30 days prior to delivery. Otherwise, it is inadequate treatment. So, and the number of doses depends upon the stage of syphilis. So primary, secondary, and early latent syphilis, as I mentioned earlier, you just need one dose of bicillin. If you can catch the moms in that group, then awesome, just one dose. But if it's late latent or it's latent syphilis of unknown duration, you've got 3 doses, each 1 week apart, and the moms cannot miss a dose. You miss a dose and you miss a week, you have to start completely over. So making sure these moms have adequate follow-up and retention is a really difficult thing at times, and whatever can be done to empower them should be done. All right, so case number 2. I have a woman who comes in at 37 weeks into labor and delivery. She has what they call a rapid T-pallidum IgG and IgM CIA that is reactive. They reflex it to an RPR, it's non-reactive. She just moved from out of town and you don't have access to her prenatal care records. This is a call I get all the time. So the question is, why is this woman's RPR non-reactive? What do I do with these 2 discordant tests? So there's some possibilities here. 1, the original screening test is a false positive. B, she could have been recently infected and hasn't had time to develop titers. Or C, she could have had something called the prozone effect. We're going to go through these. So, all right, the false positive test. So how do you test? Well, there's the non-treponemal test. And this is, if you were my generation or before, you were very familiar. This was your initial test for syphilis. So you have an RPR, the rapid plasma reagent, or the venereal disease research laboratory test, the VDRL. These are not sensitive and not specific for syphilis at all. They can be positive in other conditions. So that's why they call it a non-treponemal test. Being pregnant can just make you positive, or having a connective tissue disorder can make you positive. So they can be negative if early after infection, or if somebody's had latent infection and been infected for a while, they may have kind of burned themselves out and be non-reactive. Or they can be false negative due to the prozone effect. And I've got a whole slide devoted to that, so hold on to that one. All right, so then the treponemal, and you cannot compare the RPR to the VDRL. They are not one and the same. Or an RPR being 1 to 4 and a VDRL will not be 1 to 4. The VDRL tends to be more than the RPR. So and there's no equation to like plug into. You just you have to pick one and stick with it. But these numbers rise and fall with treatment and also with infection. So the treponemal test, so the TPPA is the most sensitive and the recommended one. There's also one called the FTA-ABS, but it lacks quality controls. It has some subjective interpretation. It requires a microbiologist. Basically, it's a pain to do, but it's pretty good, but it's just a pain. And then there's the MHA-TP, which has poor sensitivity. So the one, and all of these treponemal ones over here on the right, over here, these are positive for life. So you cannot monitor response to therapy with those. Unlike this one, the RPR and the VDRL, you can monitor therapy with. So when you're ordering a treponemal test, the TPPA is the one you really should be recommending and should be obtaining. All right, but there are these new treponemal tests that came out since I graduated from medical school. And they're enzyme immunoassays or chemiluminescence assays. If you see them from UAMS, they call it a T-pal. IgG is usually what it shows on the results thing. So these are automated. So they're real easy to do. They've got a really fast throughput. There's about 13 of these tests on the market, and they target some combination of the treponemal antigens, but they're less specific than the TPPA. So they're a little bit better than the RPR, but they are not perfect. And their aggregate specificity is about 94.5 to 100%. But when you think about the volume of mothers getting tested for this is, you're going to have some false positives in there every once in a while. All right, Now, how long does it take to have a reactive test? Well, if you were to get infected with syphilis on New Year's Day, it can take up to 90 days for your RPR to become positive. In fact, the Red Book, the latest edition of the Red Book recommends that if a sexual contact is identified within those 90 days, that you go ahead and treat regardless of their serologic response, if they're pregnant or if follow-up is uncertain. So then the prozone effect. So this panel A is a normal ELISA. So you have one antibody here, you got your antigen, and then you have another antibody. And the whole goal is that you're gonna cross-link these. And once you cross-link these are positive. Well, the prozone effect is over here with B. And that's where you have so much antigen that every single antibody is coated with these. And so there's no cross-linking as possible because the antigen is just thoroughly saturates it. That's the prozone effect. That means you're really stinking positive, basically. So, and the way to get around this is you dilute your specimen and go from there. So there are testing approaches. So back before 2010 or so, we did the conventional algorithm, RPR followed by a treponemal test. Now, a lot of institutions such as UMS is using the reverse sequence algorithm. And that's where you have that quick test, the TPEIA, followed by an RPR, and go from there. And that's been incentivized just due to manpower issues and cost issues. So on the conventional one, this is what I grew up learning. You have an RPR, VDRL, it's negative, okay, move on. Your RPR, VDRL, it's positive, then you confirm it with your TPPA. If it's negative, oh, it's just a false positive. If it's positive, you need staging and treatment. All right, going with the reverse sequence algorithm, you just added this other step that can be pretty confusing. So you have a rapid test, it's negative. All right, moving forward. There's no syphilis, no further testing. But if it's positive, but your RPR is negative, then you have to confirm with a TPPA. And if that is negative, it's either a false positive, rapid one up here, or it's an early stage of infection and you have to consider retesting in 4 weeks. So if you relook at case number 2, a woman at 37 weeks comes into LND, the rapid T-Paladin CIA is reactive, but the RPR is non-reactive. What do you do, especially if you don't have any other records? So one, you ask the lab to dilute the sample to make sure it doesn't have the prozone effect. If she could have a new infection, it'd be too early for the RPR to be positive. So you ask about risk factors and consider repeating in 4 weeks. And then also it could be just latent syphilis where it's burnt out the RPR, and so you send a TPPA on the mother. All right, so this is our wonderful algorithm. And I say wonderful because this is everybody's reaction whenever they see it. That is in the Red Book that kind of helps you go through what happens when you have a mom who is positive and what do you do with the baby. It's really complicated and tedious and can be mind-blowing. So the simplest way to break this down is to look at the top part and just be like, all right, whoops, sorry, my mouse is very sensitive, and we'll move things forward. Don't do that. All right, so the top part is mom's labs. And then once you go through mom's labs and get mom's labs, you get mom's history, and that gives you mom's status. All right, so then once you determine mom's status, basically this algorithm walks you through and say, mom does not and has never had syphilis, then the baby's fine. If mom has had syphilis in the past and was treated appropriately and hasn't been reinfected, then the baby's fine. But if mom has syphilis now, you have to treat appropriately. Then if we really are not able to clue into what's going on, then you just have to investigate further. So again, I think I duplicated the slide. Adequate maternal treatment during pregnancy, benzathine, penicillin, greater than 30 days prior to delivery. All right, so once you have mom's status and you have baby's labs and the physical exam, that helps you to determine these different AAP categories. So I'm going to try and use my mouse and not advance the slides, but The big ones are proven or highly probable congenital syphilis and possible congenital syphilis. These are the ones that usually end up with 10 days of IV penicillin. But the short answer to all of these is penicillin is for everybody, basically. So we'll go through, I've got an example here, coming. So proven or highly probable congenital syphilis. That means that the mother was inadequately treated or had signs of new or reinfection, and that includes rising titers or a newly diagnosed partner. The baby has an abnormal exam or a baby with abnormally high titers that you can't otherwise account for, like they're higher than mom's. Then you're in the proven or highly probable congenital syphilis group. So, and that, again, definition is an abnormal physical exam or a fourfold higher RPR or VDRL than mother's, or positive dark field test or PCR for syphilis. And that child should be evaluated with a CBC with diff, LFTs, should get a lumbar puncture, and you include a CSF VDRL on that, and then doing some neuroimaging, long bone films, optho exam, and a hearing test. So case number 3 is a 6-week-old who comes in with failure to thrive, and he had hepatomegaly and a rash. Mom had a lesion present on her perineum at birth that was biopsied, but an RPR was not done at delivery. After that, mom was called later, and it's like, oh, your biopsy was positive for condyloma lata. And the baby at that time had developed this rash that you can see, these big macules that are peeling, that are present throughout the body and on the hands and on the feet. And the baby's RPR was 1 to 128. And the rest of the workup, so this child had a hemolytic anemia that on admission, his hemoglobin was 9 and dropped to 7 and required several transfusions. He was slightly thrombocytopenic and had a transaminitis. And his white count in his CSF was elevated, and we didn't have another cause, so we considered him as having neurosyphilis as well. And his x-rays, if you look at his x-rays, this is, if you look at the heads of his humerus and how they're just kind of all moth-eaten up, that is part of the bony changes that you see with syphilis. So this child met criteria for proven or highly probable congenital syphilis. And so he got 10 days of IV penicillin G. If you are treating a child in the first week of life, well, that dosing interval is Q12 hours for 7 days. And then something magically happens to the kidneys on day 7 to day 8. And they magically turn on and start peeing out all the penicillin. So you got to up the dose frequency to Q8 hours. An alternative is to do IM procaine penicillin daily. I would say that with this IV penicillin G, it's hard to do that in a smaller hospital that may not be able to do PICC lines in a younger child. So, so case number 4 is a 10-week-old infant who came to clinic. Mom was concerned the baby may have syphilis because she just tested positive when she went to donate plasma recently. So now she's worried about her baby. 2 years ago, she had an older sibling, negative test. But then when she was 30 weeks, the dad donated plasma and was found to be positive for syphilis. Then he goes off to jail and nobody knows what happened to him. And mom had her OB test her at the time, and the RPR at that time was non-reactive, but she didn't get treated and they didn't retest her again. So child was born at term, no complications or anything. And it wasn't until giving plasma that when the child was 9 weeks old, that this positive test on the mom was found out. So why was her syphilis screen negative at 30 weeks? Well, it may have been because it was too early to be reactive because it wasn't in that 90-day period. It was in that 90-day period, or it could have been the prozone effect. And when she happened to present at her OB like that, she probably should have been or gone ahead and been treated with IM penicillin. But the infant's exam was completely normal, and her RPR was 1 to 32, which was the same as mother's. But following the algorithm, we ended up treating her with 10 days of IV penicillin just in case. So again, possible congenital syphilis, if you follow the algorithm, is a normal exam, and the RPR VDRL is the same or less than 4-fold of mother's, and mother was incompletely treated for syphilis. And the evaluation is all the same. And our child's evaluation was completely normal. There were 10 days of IV penicillin G given. And then there is this caveat that if you do the full evaluation and it is normal and follow-up is certain, which I have to say with this population, follow-up being certain is iffy, that you can give a one-time dose of benzathine penicillin G and have them followed up in clinic and follow that RPR in clinic. I rarely do this. And I make sure that whoever I'm talking to out in the community who's wanting to know about this, to be like, if you do this dose and you say mom's going to follow up in clinic and they don't follow up, then that's a DHS call, and make sure that the parents are aware of that. So after that, you have congenital syphilis less likely. And that's when the child has a normal exam. The RPR is the same or lower than mom. So mom's like 1 to 4, baby's 1 to 2. And the mother was treated appropriately, and there's been no signs of relapse or reinfection. And this has been documented and is verifiable. If it's less likely, congenital syphilis less likely, so you go through the algorithm and it puts you out at that spot, then you don't have to evaluate. It's preferred that you just give a one-time dose of that benzathine penicillin, and then, or you could do no treatment, but follow up that baby every 2 to 3 months and make sure that the RPR goes to negative by 6 months of age. Congenital syphilis unlikely is a normal physical exam. The baby's RPR is the same or less than 4-fold mother's, and mom never had syphilis during pregnancy. She was treated adequately prior to pregnancy, but it's just serofast. Some of these women will just have an RPR of 1 to 2, 1 to 4, 1 to 8, something low like that, 1 to 4 or less usually, and they just won't ever make it go to 0. Their body just hangs on to it. And if you can prove based off of documentation, and usually the health department, when you call them, will say, oh, that mom's just serofast. We've been following her for forever. Then so that makes the child have congenital syphilis unlikely. And this is, again, the definition of serofast: low stable RPR VDRL, 1 to 4 or less, despite effective treatment. That is most common in people treated in late stages of syphilis or seen an HIV co-infection. And that one, if you have uncertain follow-up, you just give them a one-time dose of benzathine penicillin, or you just have no treatment necessary. You just keep following them until their RPR or VDRL is negative. If they have a negative RPR or VDRL, sometimes the Red Book was like, you don't have to treat them, but you might just keep checking to make sure that it wasn't like a late stage infection late in pregnancy. So there's that. But syphilis itself, I'm kind of running out of time, is a Swiss cheese model of syphilis prevention. There are plenty of things that have to happen to prevent a child from getting congenital syphilis. Number 1 being appropriate maternal testing, another being appropriate maternal treatment, and appropriate infant evaluation, treatment, and follow-up. All of those things need to be in line to prevent a case of congenital syphilis. So some basic tips that I have is that you need to make connections with the health department. Stephanie Lovell is my point person, and I've got her phone number programmed into my phone. So I can call her whenever I need to. She can help you get your records. If you are not in Arkansas, know your local epidemiology, know who to call. The Red Book chapter, the algorithm is on page 734. And I can tell you that I have it like right here. And when you're going through it, be slow and thorough. Like, this is a child you're not trying to rush through in 5 minutes before the next delivery. You need to devote some time to going through all of this. And you can always ask for help. The infectious disease division here is always happy to help you work through all of this, because we know it's confusing. We studied this thing through fellowship. We know it's confusing. So we are happy to try and help. So that is all I have. if you guys have any questions or anything. I know I went through it really fast. It's just really dense material. So any questions? I'll stop sharing my screen. Maybe I can. I see one in the chat. Does ACOG recommend those timings for screening as well? I'm not sure about ACOG, but that is definitely the health department's recommendation, as well as the CDC's recommendation. I'm not sure about ACOG, but there's been a lot of talk about trying to get our OB-GYN colleagues to be on board. And it, UAMS does an excellent job. Like every baby, every mom, as long as they're showing up to get prenatal care, I mean, we've got serial RPRs to keep following and in the records. It tends to be some of the smaller practices that I've had a couple of people slip through the cracks that I've had problems with. But the health department is reaching out, trying to get people to screen at 28 weeks as well and at delivery. Any other questions?
Dr. Young, this is Gary Wheeler. I wanted to congratulate you on your lecture. This, as you say, is one of the most painful things I've had to do in infectious disease, is to keep up with all that. And I concur completely with your points about, you just got to recognize it's complicated and seek out help to make sure that you, and as you know, you and I and others would sit around when he had a case like this and make sure we all agree on what the choice is. And sometimes we didn't. But I think for people in the community, that's really, really helpful. I also want to say one thing, and from my perspective, working at the health department, the health department is run by human beings who are sometimes fallible, and they go out and try to get data from people who are sometimes fallible. So sometimes you do have to be persistent with these kids because of the consequences. And I know that's what all pediatricians know how to do, but this is one of those areas where you really have to.
Mm-hmm. So children who need ID clinic follow-up. So definitely anybody who I would say definitely anybody who has was treated for proven or highly probable congenital syphilis, possible congenital syphilis. Even, we're happy even to see the kids who just have a positive RPR, and just to kind of help pediatricians go through that. But if it's one of those things where you're like, oh, this mom is just serofast, and the baby's fine, we don't always follow those kids up, because sometimes these kids are coming from Jonesboro or somewhere far away, and it just seems like a really long trek. We do try to, when we communicate with the nursery provider about these kids, be like, yes, definitely we want this kid to get follow-up. We'll give them a date usually pretty quickly, and we usually see them at about 2 to 3 months of age is our first follow-up. Some of the lower risk kids we don't always follow, but definitely any of the higher risk kids we will. What about telemedicine follow-up, Dr. Wheeler? Oh, we have been discussing that. COVID has kind of taxed us a little bit, but that is one of our goals would be to some way to have, especially if the blood could be drawn at the local health unit, and then we could just do a telemedicine visit. I completely recognize that driving to Little Rock for just an RPR draw is kind of a huge burden on families. We'd like to offer something else. If COVID would go away, we might have the bandwidth to make that happen a little bit faster. But Dr. Dulski, you've got your hand up?
Yeah, thank you. Are you able to hear me okay?
Yes.
Great. I had a question about a specific clinical scenario, but if you're seeing a patient, a newborn in clinic who is in foster care, and according to the birth and prenatal records, the mother maybe didn't get adequate screening, but it was never redone at the time of delivery, are there any recommendations then for following the baby or testing the baby moving forward?
Yeah, I would say that if at delivery there was not an RPR on the mom, and you have that baby and you're in your office, and you don't have any other options, I would go ahead and get an RPR on the baby in the office. And it'd be one that I would keep an eye on. Hopefully, and that's the foster care situation just sucks because you just don't know if they're going to stay with you versus going, moving to a different person. But I would definitely be following that child closely and just watching for any of those signs of early congenital syphilis. But if you don't have anything on the mom and you have the kid there at their, Billy check, while you're checking their Billy, I would check an RPR too.
Thank you. And then is there a certain time by which, like congenital syphilis, if it's going to become symptomatic, it will have already become symptomatic?
So early congenital syphilis, the peak for that is usually around 6 weeks of life. For that early, like the first case, the case with the rat with the little circular lesions and everything, that's usually 6 days of life, or 6 weeks, sorry. Late congenital syphilis, that can take, the peak for many of those manifestations is honestly around puberty. So yeah. I'm very curious what we're going to be seeing in about 10 years with this spike in congenital syphilis cases. There have been cases that we've missed that, in 10 years, am I going to be getting referrals to kids with hearing loss and a positive RPR? I'm very curious if that's going to have to, if that's what's in our future.
So really, it would never be too late to grab the RPR if the mother didn't have it done and the child hasn't.
Correct. It's
Okay.
never too late. And honestly, so if there's a scenario where like maybe the mom got infected like, a couple of days before birth or something like that, and she was negative at delivery, there's a recommendation that you can check, around 3 months or so, that would be a good time to check to see if the baby has incubating congenital syphilis. So, so I guess that's some, just thinking through it, you could easily for those kids get, I don't know if this should be like a formal AAP recommendation or not, or if it's just Heather's gestalt, that you would have, your Billy check first, baby check, RPR, and then check again at 3 months of life. I think that would be a pretty fair check to make sure that the child's not incubating congenital syphilis.
Thank you.
Anybody else? It's a real, y'all, this is all ID doctors hate this topic just because it's so hard. And I just kind of fell into it by default because we just had so much in Arkansas. I just kind of had to learn it even more than I did in fellowship. But if you are close to OB colleagues, like if there is a group where you regularly attend the deliveries, and they're not checking, you might bring it up that there's a huge, people are not social distancing enough to keep from getting syphilis right now. And so we are certainly seeing these spikes and they need to be testing as often as they can. And I've had couples where everybody swore they were monogamous and then somebody was not. So just because you have a perfectly appearing monogamous couple does not mean that you truly do. Okay. So, I don't know. Anything else?
Besides the graph that you showed about the colorful one about, no prenatal care or regular prenatal care, but not testing, is there any other hypotheses for why syphilis in general is becoming more common?
I think people are not testing. Most people have forgotten that syphilis was a thing, like most physicians. When I talk to people who are maybe 10 years older than me and in medicine, they're like, syphilis, what? I haven't even seen that. And I'm like, oh, well, I have. It's just that, especially in the early 2000s, there was such a dip. It was so low. And, we're seeing all STIs increasing. I mean, gonorrhea and chlamydia are also increasing. But with HIV, there's enough antiretrovirals that we're not quite seeing that same increase. But it's a different beast. And so people are not having safer sex, and physicians are forgetting to screen for it, or have forgotten what syphilis is. So I think that's the main hypothesis. We've got 2 minutes left.
Thank you, Heather. It's
You're
awesome.
welcome. Your baby is so cute.
He's a little fussy, but he's fine. Yeah.
Yeah. They're definitely, Dr. Williams, that people are definitely not social distancing enough. They are still, they're spreading COVID and they're spreading syphilis. Like,
What about including syphilis in routine STD screening, even in non-pregnant or non-high risk individuals?
so technically you're supposed to be screening for it, not in somebody who's like in a quote monogamous relationship or whatever, but just like you're screening for it, you're supposed to screen for HIV at certain, regularly throughout somebody's life. You're supposed to do the same thing with syphilis. Basically, if you're going to order an HIV test, if you're going to order any STD testing on somebody, you should order an RPR too, or whatever your syphilis screening mechanism is of the day. I know that our adolescent clinic is definitely screening for some syphilis. I get calls from them a lot.
Yeah, maybe I need to look at the guidelines. I do that, but I thought when I had looked, some guidelines still recommend it as part of like high risk and not necessarily part of like gonorrhea, chlamydia, HIV routine screening.
Well, I can just tell you that Arkansas is high risk. If you live in Arkansas and have sex, you need to be checked. You need to have an RPR checked. Okay, I think they're going to be sending us back to, yep, I think we're leaving the breakout room in 60 seconds.